35-year-old male. He's a 35-year-old male. He's a serving soldier. He's otherwise no known comorbidities. He was recently treated to a hypertension in 3-4 months back. So he presented with a history of sudden onset of headache with vomiting, and during initial in the morning hours when he was just about to getting ready for his morning works, and he had vomiting, sudden severe headache, and with initial 2-3 episodes of vomiting. So he was admitted. He was not taken to a service hospital because there was no service hospital there. So he was admitted and treated in a local hospital where imaging was done. The imaging revealed a diffuse aneurysmal SAH, and it was a grade 3 SAH, no IVH and no hydrocephalus. This was the initial first CT. So since he was far away from a service hospital, he was managed conservatively there, and he didn't have any neurological deficits. His sensorium was okay, and after his improved in sensorium, improvement in general condition, he was referred to our command hospital, Central Command Lucknow. During the time of admission, he was referred to us after a week of 12 days. And during time, he did not develop any deficit, any other further headache. He had mild occasional headache only. There was no deficit. His GCS was full, 15 by 15. And I'll just share you my packs. So we initially, after seeing this, after seeing he had already undergone one CT angio, where it was initially reported as normal. So we directly took him up for DSA. So this is the first DSA. We had a suspicion of small blister-like aneurysm in the communicating segment. Again, small. It is separately seen from the origin of the PCOM. Here. It was very irregular, and now with a zoomed injection, you can see the irregular aneurysm. So this was the initial DSA. So after that, because of this small blister aneurysm with no other deficit, we had planned for a flow diverter treatment for this patient. So we planned it in the next sitting, immediately on the next sitting. So we had loaded, since we don't have this protocol of clopidogrel and the platelet function test in our institute, we directly loaded him with a loading dose of 180 mg ticagrelor a day prior and a 90 mg ticagrelor in the morning along with ecosprin. And then we took him up for intervention, this under GA. So this is the initial guide catheter injections, which showed we used the hardware which we used was infinity long sheath over which we took a guide a neuron 6F neuron, and so the initial injections, guide injections. This that will be. So this after this, then we introduce the microcatheter. We use since we used P64 mobile wire HPC, which was available with us. Then we took the separate microcatheter. That is a Phenom 21 microcatheter, and there's a guide injections after deploying the microcatheter. Here, microcatheter, and we started after. Then we took up the devices on the along the M1 MC on the right side. So then we started with the initial, after pushing the device for the initial starts to open, then with push-pull technique, we deployed it. So this is the deployment of the flow diverter. I'll just zoom it. The initial deployment. So the distal end is approximately about to get deployed after deploying. So you can see the deployment of the flow diverter. So initially there was some hiccups in the opening of the proximal end, and then this was provided with a movable wire. So with the movable wire, we just pushed in the movable wire, then it clearly opened, and it was a good opposition had occurred. This is an injection. You can see some stasis in the aneurysm after deployment. So final injections. There was some slowing of the right A1 ACA. So we waited for some more time, and then, but it filled up subsequently. So he didn't do anything after this, and he came out. It was procedurally was it was uneventful, and the patient was extubated in the same day, and he was continued on dual antiplatelets, and he was kept on follow. So this is the MR angio which we did on the first month follow-up. The patient didn't have any deficit. This is CT angio which so the deployment was okay, and follow-up CT angio. But we had a doubt about this caliber of the A1 ACA as well as the initial the proximal ICA. So it was attenuated in caliber, but the patient didn't have any deficit. So we continued on dual antiplatelets, and we again called him up on after 2 months. Since there was some suspicion of this narrowing, sorry, didn't see. So we did a follow-up DSA after 3 months because of these issues. But the patient was absolutely clinically asymptomatic. He didn't have any issues. This is the opposite side. See, on the ipsilateral side, there was severe narrowing of the uh, supracondylar ICA as well as the M1 MCA. We couldn't see the A1 ACA at all. So from the opposite side, it is totally supplying the MCA territory as well as the peak from the posterior circulation. He had a good supply from the. So the collaterals have taken over the primary as well as the secondary tertiary collaterals, pile collaterals have taken over the entire right ACA as well as the MCA territories. So then we did fluoroscopy. If we see, I'll just zoom in. Was total distortion of there was severe thinning as well as narrowing of the vessels along with the distortion of the flow diverter. I'll just show you the so this is the initial few images for better clarity. So this is the initial aneurysm after deployment. And we, as you can see, the deployment images of the flow diverter. Good wall opposition. There was no kinking, no fish mouthing, nothing had happened. And the initial post deployment angiographic images. So now here in the zoomed images, you can see there was the flow diverter has got some irregularity along the wall as well as the internal lumina, and there was a severe narrowing and stenosis of the supracondylar ICA as well as the M1 MCA and A1 ACA, but the aneurysm is not filling. So we search for the literature and there is some instant stenosis which is happening. So what was the usual worry? So this is a phenomenon called as neo-intimal hyperplasia with vessel narrowing and deformation of the floor. Since the patient has got adequate collateral supply from ACOM and PCOM and he's asymptomatic until now. So he was continued on dual antiplatelets with ticagrelor and ecosprin with we were planning to for till 12 months we are planning for continue the DAPT and then the repeat angiography at 12 months. So we search for the literatures for this phenomenon. What is it? There is a largest series which had done after following pipeline flow diversion device. This is a 2021 article just published by Cooper et al. This is an incidence of neointimal hyperplasia. So it's more, almost 90% incidence in the anterior circulation, which more in the ICA rather than ACA and MCA. And what they had propagated was the few theories of proposals, etiologies for this neointimal hyperplasia is the increase in the metal density of the flow diverter. Like number of wires, if there is increase in the neointimal hyperplasia, which can cause stenosis. So, and plus if there is any inadequate stent expansion, that inadequate wall opposition, that is also one of the more proposed causes for this neointimal hyperplasia. So we searched various literatures what we can do for next for these patients. Very only few literatures who have done a plasty for this, but we were a little reluctant to whether to undergo the same things. The patient was asymptomatic, and we had consulted one of our few mentors also, few consultants also. So all of the opinion can continue for the DAPT for 12 months, and there was spontaneous resolution in around 60% of the cases, which the literature also shows, and few for colleagues who had also had a similar experience. And even with P64, there were instances of neointimal hyperplasia which is happening, which is solved after a period of 12 months. During the time, the patient were put on DAPT. But the only issue here is we were expecting is the hemodynamic pattern of infarcts in case if the patient collateralization is not adequate during sometimes like akin to an ICAT, hemodynamic pattern of infarcts in an ICAT. So that is one of the issues here. So this is one of the few interesting case, one of the first interesting case which we had encountered during in Kamar Hospital, Lucknow. The second case, he's a 40-year-old male, a smoker, alcoholic, hypertensive, is an ex-serviceman. Again, he presented to us in a late presentation. He had a severe headache, vomiting, with loss of consciousness. Again, managed in a local hospital. Initial imaging showed a aneurysmal SAH, but they couldn't transfer the patient to us. So he was managed conservative till day 7. So during day 8, he was transferred to us poor GCS, almost 9/15. So initially we did a CT angio. There was severe vasospasm which we could see. Almost severe. We are not able to see. We could see the aneurysm which is building up, but we are not able to see the A1 ACS as well as the proximal MCS. Bilateral A1 ACS are seen. They were just replaced by a few leisure vessels over there. And it was severely attenuated caliber of the bilateral M1 MCS also. But since it is a ruptured aneurysm, very complex lobulated aneurysm, we had to, when the GC is also low, we have to undertake, and he is a young person. So we have to undergo the intervention. So we took him up for intervention in the same sitting on the same day. So the initial angio showed severe vasospasm of the supraclinoid ICA, A1 ACA, as well as the M1 MC, and filling up of the aneurysms from the right A1 ACA. So, and again from the you can see the lateral view shows a severe absence of a anterior circulation and severe vasospasm here. The reverse Towns view shows the origin of the vessels as well as the aneurysm. And there is absence of the anterior circulation here. Total anterior circulation is absent. So we did chemical angioplasty was done. He was given 8 mg of IV nimodipine as well as we initially started with 4 mg milrinone, and then for there was not initial opening was not adequate. Then again we added 4 mg of nimodipine also. So bilateral we have given, and this was the final opening which you could manage. And there was some the ACA territory was also filling up here. So we then proceeded. They proceeded with same. Our standard is neuron max guide as well as neuron. And then is our guide catheter injection. You can see post angioplasty, there was significant improvement of the vasospasm as well as the return of the circulation in the ACA territory. So it was a very complex aneurysms with tortuous vessels. It was a very difficult case for us. It's a lateral view also, the guide catheter. This was our working projection. And then we proceeded with coiling. We used the hardware which we used for, we had a separate XC with us, but the separate XC was not tracking somehow. So we kept it on standby, and then we then proceeded with echelon and hybrid catheter. But somehow the echelon and hybrid, there was some issues. So we changed to Vasco and synchro wire, through which we coiled the aneurysms, and we put around 3 coils into the aneurysms. We could achieve MRC2A. There's some small necroment was there, but the aneurysm was excluded. The dome was excluded. This is the final picture. Small necroment. The issue here was the severe vasospasm, and the patient actually had a stormy course in our ICU. And he was given IV milrinone nimodipine for 1 week. Then he was put on tracheostomy, and he was discharged after around 25 days with a MRS, initial MRS 4 with the tracheostomy. So now he has come for follow-up, and his MRS has improved to MRS 3. And because he had this bilateral ACA infarcts had already set in during that when we took him for the intervention. So this ACA has definitely impacted his post-procedural rehabilitation, and he went into pneumonia. So somehow he managed to sail through that, and then he was discharged, and now he's improving, and definitely his deficits have significantly improved. And there's peripheral intervention case. The 70-year-old male who met with a road traffic accident, two-wheeler versus car accident with an injury. And he had a both facial as well as abdominal injury with ecchymosis, huge ecchymosis, and a lot of lacerations in the anterior abdominal wall. And there was a tenderness in the body. He was having severe hypotension. He was put on NORAD, and he was having double inotrope support was required. And hemoglobin was 6 when he initially came. So severe trauma scan was done. He was found to have a grade 5 liver injury. So this is the initial CT angio. There was severe hemoperitoneum was there. And he had a grade 5 laceration with the pseudoaneurysms, and a contrast leak was there in the arterial. The issue is the artery which is supplying the pseudoaneurysm. It's actually accessory hepatic artery, left hepatic artery, which was supplying the pseudoaneurysm, which was arising at almost from the celiac trunk, 90 degrees from the celiac trunk, and then supplying the left lobe, and which is actually the accessory left hepatic artery, which is showing this pseudoaneurysm as well as a leak into the parenchymal hematoma. So since there was hypertension, we immediately took him up for procedure, and then share the intervention procedure. So initially we took with Cobra, but we were not able to hook onto that celiac trunk. So then we did change it into catheter. So SIM2 shows the origin of the inferior accessory left hepatic artery, the 90-degree origin from the trunk, and then the leakage, contrast leak, the pseudo aneurysm. So immediately then proceeded with prograde micro through the same guiding catheter. We used him as a guiding catheter and the catheter and Sahim micro wire. Then we reached up to this place, and then we used 30% glue for the embolization of the pseudo leaking pseudo aneurysm here. And after the leak, what has happened was the glue somehow it reflects back, and then while we took out the micro catheter, the celiac trunk got occluded, the origin vein trunk got occluded. There we couldn't see the right hepatic artery, but only the splenic artery was seen. So it was a scary situation for us, and we did stent retrieval technique, but couldn't do anything. Then what we did a celiac artery SMA injection also. So finally, SMA injection shows the entire right lobe is separated by through the collaterals, the entire right hepatic artery is being reformed. So then the patient didn't have any issues post procedure, and his hemoperitoneum was managed by only pigtail. We put 3 pigtails, and then we drained out the hemoperitoneum. Almost CC was left in the next day. Then we did a follow-up CT for him. And the follow-up CT, you can see the changes what has happened after the procedure. The pigtails. So the hemoperitoneum we had totally resolved. 2 pigtails out here now. Plus, you can see the reformation of the origin of the celiac trunk. There was no trace of the filling defect, and only the pseudoaneurysm and the left hepatic artery. Access the left hepatic where the glucose is seen in those vessels, and plus the hematoma. There was resolution in the hematoma. He had some lung issues and during the stay in our ICU. But finally, the patient he went home walking with a HB of around 11, and his hepatic function test improved after a week. And right now, he's in the follow-up ultrasound. Before I came here to Pune, last ultrasound I did it. He was just having around 50-60 of intraparenchymal. That was an organized hematoma was there. Otherwise, his functions are fine. He started going to his college, and he was perfectly fine. So we could save a life in this case. So he was the case which is grade 5 injury, which is managed only by the intervention, endovascular as well as the drainage of the hemoperitoneum. So he didn't undergo any surgery. He was discharged normal LFT, and there was a good healing. So one thing which we had learned is inadvertent glue embolization. We used 30% glue, and we had to be, and since it was leaking, we had to give a slight more push. During the time we didn't actually pull it slightly faster. So during the pulling also, some of the glue which was stuck there, it came, and it is inadvertently it escaped into the celiac trunk. So it is actually, we were lucky that the SMA supplied the entire right hepatic artery, and even the celiac trunk has been reformed. So we had a lucky escape here. So this was a learning case for us. And the case 4 is the last case in intervention. It's a known case of CKD5, a lady, a 65-year-old lady with a long-term hemodialysis. She had a left brachiocephalic fistula. It was done 3-4 years back. She developed facial neck swelling and left upper limb swelling also. She underwent venoplasty and brachiocephalic means left innominate vein stenting at another hospital. About 6 months back, and after 6 months, she presented to us again with a recurrent swelling of the face, neck, as well as in the left upper limb. So we did a chest radiograph which showed a stent fracture over there. So we did a venogram and then we proceeded further. So this is the initial, sorry. So this is the initial venogram which we took it from the fistula side. The right side which shows the stent fracture and there is no flow here. the stent fracture here. There was a stenosis. There is an instant stenosis there at the fracture site. So this is a stent fracture stent. Just zoom it. So here the stent fracture is a retinal stent which is fractured. So what we did is then we went to the femoral root, we took the femoral root, and then we how somehow managed the O3 fire, how through the struts of the fractured stent, we managed to cross. We went ahead to the left upper limb. And then we started plastering the fracture stent. So we used a converse balloon with it's around 10 mm balloon, which we used here. 10 mm 40 centimeters balloon, which we used 40 mm balloon. So after plasty, this was the state. So still there was some residual stenosis. The collaterals were still not resolving. So then we put through the same fracture stent, we put a braided self-expanding stent. It's a wall stent over here. So this is a final picture here. So there is significant resolution of the collaterals. We could establish the flow back. And the next day itself, the patient had a resolution of facial swelling, neck swelling, as well as the upper limb swelling. And still now, we did it almost in Jan. Till now, she's continuing on the hemodialysis from the same fistula. So this was one rewarding case for us. So yeah, she had improved dramatically, still on HT without any complication. So for the discussion is whether they should have done a stenting in the first sitting itself. So usually the literature says stenting should be done as a last resort when the patient is not improving with the venoplasty and we had a failure, multiple fistula failures as that. Plus, and then now again we had put a stent over stent to reduce a fracture and to establish the flow. Now, should be the anticoagulation guidelines? Usually, the literature says these patients can be put on a big, newer data oral anticoagulation, that is apixaban or rivaroxaban, getting a setting of chronic kidney disease. So this patient was put on already was on ecosprin, and then because of her for multiple comorbidities, and then we had continued her on apixaban. So till now she's fine. So we'll then move to the few diagnostic cases. This is the first diagnostic case. It's a 14-month-old girl child. Initial presentation was fever, incessant crying, and abdominal distension. So a kiddogram was done because of the abdominal distension to see any obstructive features were there. So there was a pneumoperitoneum. Unfortunately, I don't have the X-rays and the initial pictures. So seeing the pneumoperitoneum, she was operated. She was taken up immediately for surgery, and there was an ileal perforation. So the cause was not known. So, but however, there was since segment was gangrenous, she was early gangrenous stage was there. So dissection anastomosis has been done. Post-op period, almost for about 2 to 3 weeks, she was having continuous fever. There was a suspicion of leak was there in a CT, and then she was re-explored. After which the CT was showing pneumoperitoneum, persistence of pneumoperitoneum and pneumo fluid collection around the post-op site. So she had an abdominal presentation here. So there was an ileal perforation which has been operated, and again a re-explore, which toileting was being done. But on day 2, she develops status epilepticus, and CSF was done as a child. It was normal. Viral panel was negative. GCS was poor, and she continued to through seizures even with multiple anti-epileptics, and she was having continuous fever. So because of the status epilepticus, she was taken up for a MRI under GA. Bad images. It's not just a contrast. It's multifocal flare hyperintense lesions, heterogeneous gray white matter junction, as well as in the deep white matter. Few are appearing nodular. With if you can clearly zoom it, I'll just zoom it and show you. There was some target-like appearance in few of these lesions. So hemorrhagic lesions, multifocal lesions in the gray white matter junction, as well as in the white matter in a child who had initially had any. So mm, the diffusion revealing much. Few of the lesions are showing diffusion restriction. So we're actually had no loss. So we had initially given the patient has got ileal perforation, now had presented with status epilepticus MR imaging showing multifocal white matter as well as gray white matter junction lesions, which more few of them showing restriction as well as few of them showing hemorrhagic changes, susceptibility changes within this. So we thought of initially we thought of severe form of autoimmune pathology which is happening here because uh, this is ileal perforation was spontaneous. She didn't have any antecedent fever or anything, any because typhoid and all everything was negative here for the child, and plus she had a abdominal pathology plus this pathology, some immunomodulatory change, immunal pathology was thought of. So we actually had a given diagnosis acute hemorrhagic leukoencephalopathy in this picture. So this is a post contrast images. Was a heterogeneous enhancement. Few leptomeningeal enhancement was also seen. Subtle leptomeningeal enhancement was also seen. So multiple lesions. Even the posterior circulation we had can see multiple lesions. There was a folial enhancement was also there. So in first we had thought of only in infective pathology of some fungal pathology with such fulminant lesions. Then the second was a acute hemorrhagic leukoencephalopathy where severe aggressive hemorrhagic form of edema, which we thought of post-infection. So that's what we thought of, and spine also didn't reveal any enhancement. It's a post-contrast flag which showed the enhancement as well as the target-like enhancement here. So the patient was, since the patient was not improving in our setup, we don't have a pediatric neurologist. She was referred to HRR, where she underwent a further workup. And any takers for this case? In fact, I had even consulted HOD here, and as well as I had shown this case to Joyce. So we had this fungal versus AHLE. That was this thing. So can anyone, any takers for this case? This was then turned out to be a familial hemophagocytic lymphohisticytosis on genetic analysis. So out of this, FHLH has got four genotypes where a pair of one as well as STX11, STXBP2, and UNC13D mutations was there. So this patient had got a STX11 mutation was there. And we went then search for the literature how this because it's the first case we had encountered a CNS hemophagocytic lymphohistiocytosis. It actually had is one of the AJR article which had a largest case series of these cases from around 57 children they had when they had established distinct MR imaging phenotypes for these cases. So there are actually three phenotypes there in this. One is diffuse multifocal lesions where you can see that target-like lesions akin to AHLE here. There are those target-like lesions can show some hemorrhage. So those target-like, that's one phenotype. Second phenotype is the brainstem predominant disease, which is mimicking clippers. And there's a third phenomenon. Third is cerebralitis kind of a pattern also can occur in this setup. And this is the second case is a 9-year-old male child who had presented with fever, altered sensorium, and generalized tonic-clonic seizures. So initial evaluation in CSF showed 8 cells, lymphocyte predominant, the elevated protein. Then he was then subjected for the imaging. So diffuse hyperintensity as well as swollen caudate as well as type in the diagnosis. And then she was further worked up for the same, and then she was found to be positive. IgG was positive for EBV. So she was recovered dramatically with steroids and antivirals. And we did have repeat imaging, which showed the complete resolution of these hyperintensities in the deep diameter nuclei. So another case is a 30-year-old male, adult male, again presented with fever, vomiting, altered sensorium, dental tonic-clonic seizures. So initial CSF was not in, he was directly subjected to imaging. Again, multifocal means flare hyperintense lesions with a rim of flare hypointensity and cremoid junction with significant edema and mass effect. And this is affecting bilateral cerebral hemispheres, but how the brainstem and the cerebral hemispheres was bad. And patient was very uncomfortable. But SWA, what we could manage was we could see some magic intrinsic magnetic circuit clot effects within these lesions. So since it's just suggestive of bleed, so diffusion and was not contributory because in view of the cerebral changes within the lesions, E2 shows heterogeneous nature as well as the hypointense force of bleed. This staining seen within the lesions. The lesion had some peculiar appearance, like sort of lesions, dirty looking borders, irregular margins, and hypointence, as well as central necrotic areas showed again a lipid lactic peak as well as a protein trisimine loss. Uh, Tough MRA so was initially done because to see any other changes, vascular changes happening there. So it was not contributory. Again, since it's a hemorrhagic, veno was also done. Again, we didn't have major dural sinuses as well as the internal deep veins were normal. So this background, the patient was further investigated, and since his fever was continuing, the fever protocol we did. So fever protocol, what this is a summary of the findings: T2 flat, T1 SWA, as well as the post-contrast enhancement. So this patient turned out to be dengue hemorrhagic leukoencephalopathy. His serology came positive for dengue in this case. The one peculiarity we was observed in this case is there is lack of involvement, non-involvement of the deep diameter nuclei. There is not thalamic involvement was not there. There was predominantly cortical and subcortical involvement, multifocal, but a cortical involvement. This is an atypical dengue hemorrhagic leukoencephalopathy, which very few cases have been reported. And usually without cortical cases, cortical involvement will be there, and usually it presents with thalamic and deep gray matter nuclear involvement. Yeah, predominantly lentiform nuclear involvement is there. So without involvement of the deep gray matter and thalamus, only the cortical involvement. This was one of the few curious things about this case. So last case, male child with a global developmental delay with the associated clinical findings of hepatomegaly, congenital heart block, and eczematous rash in the body as well as in the limbs. So with the maternal history of an SLE, so the patient was subjected to imaging. 3D flare actually didn't reveal any significant. I will show the flare axials. Doubt for hyperintensities in the periventricular white matter, but very subtle, only in a narrow window we could see in the console. And even T2, the myelination was appropriate for age. There was some volume loss, was there was some hyperintensity along the periventricular region. But what was striking was the diffusion here. Just So there was a diffusion restriction along the radiation, periventricular white matter tracts, and as well as parahippocampal gyrus, cerebral peduncles. This appearance was quite classic for us. We thought then we went further into the literature. We searched for the lesions which showed diffusion restrictions. We had few differentials like mitochondrial and MSCAD, as well as then one few case reports we had come across which showed almost similar picture of biotinidase deficiency. So we gave these three possibilities: biotinidase versus mitochondrial, as well as so further workup was done for the child, and it turned out to be a serum Bitinase, she turned out to be Bitinase deficiency, which was proven here. So the clinical findings, like the neurological, neurodevelopmental delay, seizure, which were there. The dermatologically, she had eczematous rash and seborrheic dermatitis, and plus, but the respiratory problems in alopecia were not there. So laboratory findings which usually get is abnormal, is elevated alkaline lactate pyruvate levels were elevated. So confirmed by the blood serum biotinidase activity. So this patient was confirmed by the biotinidase activity. She was is one of the treatable metabolic and neurometabolic disorders which we could come across, and the patient has been started on the replacement therapies. The follow-ups awaited for this case. So with this, I rest my cases, and I would like to acknowledge my colleagues there, my mentor and senior advisor, Colonel Janendra Jain, neurologist Colonel Rajiv Ranjan, and the Department of Pediatric Surgery for these cases, for helping with the cases, the IR team, as well as junior residents at the Command Hospital Center, Command Lucknow.